Okay, so our final speaker I would now like to invite up is Jim Rourke, who was, until very recently, the Dean of Medicine and Professor of Family Medicine at Memorial University in Newfoundland, and has obviously a lot of experience with rural health. So, Jim.
Well, thank you. It's a delight to be here this afternoon and to still see some people in the audience, and that's great. And it's not dark out yet quite, but I've got a big task to see if I can get a laugh out of you, as that was a challenge for the previous speaker, and it was a tough crowd, so we'll see how we do. So what I'm talking about is a rural roadmap for action, capacity development and planning for rural and northern healthcare needs. And just at this point in time, I would like to recognize the land, the Indigenous people of the land, and all of our ancestors, including my own grandparents and parents, so, and for all of us. So let's just move into the topic. And here's my friend Herman, call the doctor. And I think it's just a reminder to us that no matter who we are, no matter where we are, we need to be able to access the healthcare system. And since I'm from Newfoundland, the nautical theme is sort of the right appropriate approach here. But I'm ahead of myself. So just step back a minute. The second obligatory, whatever, slide is a disclosure slide, and I've been trained that I'm always have to do my second slide. So I have no conflict of interest, except I'm probably pretty biased. I've been an active rural physician starting in 1977, and probably since then I've been advocating for rural health care, heavily involved in just about anything to do with rural medical education, from delivering 740 babies to doing many nights in the intensive care and looking after sick patients, to house calls, to everything I could do. More important to this talk, I was a member of the Advancing Rural Family Medicine Task Force of the Society of Rural Physicians of Canada, the College of Family Physicians of Canada, that produced the Rural Roadmap of Action for Action, which is really the topic that I'll be using to discuss today. And to even make it more biased, I'm just now the current Society of Rural Physicians co-chair for the Rural Roadmap Collaborative to try to advance the rural healthcare process. So I suppose my perspective is from a physician background perspective, and it's from the two organizations looking at this rural roadmap, so it does give that kind of bias to the talk, or that perspective, I suppose, is a better way to put it. The Advancing Rural Family Medicine Collaborative Task Force had really a broad representation from across Canada, leaders of organizations, people who work in the field, and that's just a list of names there. A couple of quick acknowledgements. Images used throughout this, courtesy Newfoundland Labrador Tourism, College of Family Physicians of Canada. My wife, Dr. Leslie Rourke, was a much better photographer than myself and Dr. Michael Jong. Much thanks to Ivo Anderson for ARFM, that's what we called the name, Advancing Rural Family Medicine ARFM support, and Oliver Hurley at the Center for Rural Health Studies for technical support. So, who has been there? Anybody tell me where this is? Sure, Susan. Western Brook Pond in Grossmoor in Newfoundland. So just sit back in a minute and pretend you're on a hike out in your favorite spot and get ourselves into the mood for this talk about rural, remote, and Indigenous health and health systems. So just position yourself there. I was out in Grossmoor just about a month ago, and one of my favorite places in the world. Many other wonderful spots across this beautiful land. So the Rural Roadmap for Action really lays out directions, a plan of action, and the really interesting thing to me listening to today's talks, which I found fascinating, is I think this really is a summary of what we heard going on today. Like it touches on so many of the things that are already happening in Ontario that you're already working on. So it's a pretty exciting thing, and so perhaps I'm in a way summarizing the day, although that's the job of Steiny Brown to follow at the end of my talk, but this is a bit of that kind of summary. So just sit back a bit more in our journey through rural and remote Canada, and picture yourself visiting or living or working in this beautiful rural community, and just settle in how comfortable that is, and it's a sunny day, and how nice it is. And then the fog rolls in, or the snowstorm rolls in, or whatever rolls in to make access to our communities difficult. And imagine that you're seeking care for some fairly serious issue. Who here has ever been sick in a remote or rural part of the world? Yeah, I've been really sick in Haiti a couple of times. That's a scary experience. And, or rural Canada can be a scary spot. And I've been a healthcare provider in those rural places. And it's a scary spot when you have somebody really sick and you just don't have the resources locally to deal with it. And so we're trying to look at how can we increase local resources and make it work if you don't have the local resources to deal with it. So the talk's really going to talk about the 4 directions in the roadmap. I guess 4 directions sounds like we're going in 4 different directions. Maybe we don't know what we're doing, but anyway, there's 4 directions. And direction 1 is reinforce the social accountability mandate. Now, I know it's late in the afternoon, so I've actually highlighted in red the only things you really need to know from the slides, right? So you don't need to read all the rest of the stuff. It's just the quick little words that'll stick in your mind and that. So the social accountability mandate of medical schools and residency programs, policy interventions that align medical education workforce planning, establish practice models that provide rural and Indigenous communities with timely access to quality care. Isn't that what we've been talking about all day? Establish a national research agenda to support rural workforce planning aimed at improving access. Now, at this point in time, I can emphasize one or the other of these more than the other. So I'm going to go through them as a question each time. Put your hand up if you think this is the one you want to hear more about than the others. Direction number 1. Who's big in that one? Okay, we won't do too much on that. Direction number 2, policy interventions. Oh, I see 3 hands for that one. Practice models. Oh, I see about 15 hands for that one. National research agenda. Oh, I see about 4 hands for that one. Who wants me to keep it short and get out of here in a hurry? Oh, they're all up for that one. All right. Okay, so this one we'll touch on, but I think that we heard a lot about that earlier, so I'm just going to touch on the highlights of this one. But this is trying to get social accountability mandated medical schools and residency programs to really focus on the healthcare needs of rural and Indigenous communities. In other words, addressing the needs of Canadians instead of the whims that we want to do. So it's trying to look at how we get admission processes to make sure that people from the rural and northern and Indigenous communities get into. And there's been a revolution in that regard in the last decade in Canadian medical schools. Many of the medical schools, Memorial's medical schools, have very high input. About 40% of our students come from rural, and about 10% of our students are Aboriginal at this point in time. The Northern Ontario Medical School has done extremely well with its admissions from the north, from the rural north, from Indigenous people, and other schools are starting to catch on to that. Policies and programs enable successful recruitment, and it's a pipeline program that makes that so effective, partnering with local communities. Competency-based generalist training in rural communities. I think Roger spoke about the need for the rural doctor, in fact, needs a higher level of skill to deal with a much broader and more acute caseload than often their counterparts in the urban cities who've got a whole team to back them up. And the only way to get people out in rural practice is to have high-quality residency and family medicine and medical school experiences. So as it was mentioned earlier, over half the docs in rural Canada come from large urban centres, but they get the bug to go there because somewhere along their training, they've been out, experienced it, seen that this is a great place to live and work and practice. And of course, we need to, when we have them out there learning about this, we need to make sure they learn about the health and social issues facing Indigenous peoples and attain cultural competencies to provide culturally safe care. And that's only really done properly if we partner with our Indigenous communities and partnerships. This is Chief Mizo Joe, one of my heroes in Newfoundland and Labrador, a wonderful leader of some of our Indigenous communities. And we need to forever be partnering. And I think somebody said partner, 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 or partnership, partnership, partnership. What a great theme that we heard earlier today, and highly would regard that as successful as part of the rural roadmap for the future and what's been successful to date. And it's a collaborative. We need to make sure the physicians get the skills and competencies, both family doctors and the specialists in their close by in their communities and in their regions, so they understand the needs and that we don't have all the resources. Because it's all about supporting the patients, giving the patients in those communities the best local care possible and the best transport if possible. Well, policy, this one gathered a lot of interest, and guess what? The word partnership shows up there. And the partnerships, if we look at the training, really needs to be not driven by a center bunch of bright academics, but it needs to be central support, but we need to develop rural academics, rural physicians, rural communities, community engagement for our training. And again, the Northern Ontario Medical School is a tremendous leader in this in Ontario, and it's really driven the whole idea of community-engaged medical education forward. And that's something we've been doing at Memorial University of Newfoundland since our beginning in 1967, where it was built with that idea inherent in that social accountability, community-engaged process before those words were in today's current lingo. Targeted funding. I think we heard from the previous speaker the importance of targeted funding for rural health care. And rural physicians, to keep up their skills, need to be able to go ahead and get that. So we need policies that support that. We need residents to be able to work in rural areas as part of their training. So you can't just train in the center and expect to be able to practice out in the periphery. And because if we train in the centers, we tend to get learned helplessness because there's this team to bail us out all the time right behind us. And so in rural practice, it's not quite so simple, that you have to have a bit more autonomy, a bit more clinical courage, and yet be able to pull in the regional resources when you can. And this is, again, one of my heroes, Dr. Michael Jong up in Labrador with some of our learning team. Dr. John Dodor, one of the graduates of our medical school, one of our Indigenous students beside Dr. Jong, and just the necessity of the realities of involving our students and faculty in the learning in those rural areas is part of the roadmap. Another interesting comment was the jurisdictions, and our previous speaker spoke about the different jurisdictions in Canada, but you know, if I've got a license in Newfoundland and Ontario, but if I want to go do a locum in northern Saskatchewan, I have to get a license to practice in Saskatchewan. If I do that for a month and I want to move on to Manitoba, just across the border, I have to go through the whole process again. And it's enough to discourage one from trying to go and help out other places and fill in where the needs are. So we think, again, policy here by the national locum, by the national regulatory authorities is something that could be done to make this more easily, more effectively done, and mobilize the physician workforce in a time where we should be a more mobile society. And again, in rural areas, it's not always so easy because sometimes you have major problems with, say, a premature birth, an infant that is very premature. You have to be able to transport those. Here's Dr. Jong again doing that. And one of the big barriers, and I'm pleased to hear about the hubs and the models of developing Ontario, but one of the big areas that we find in rural communities, and when things go really wrong, that transport support is often not there as easy as it should be. And it's so easy for the bigger tertiary care hospitals to say, oh, I'm sorry, we're full. And yet, if that patient had arrived on their doorstep, they'd magically find room to deal with it. But if that person's in their region